Hello students, today's topic is about perioperative hypothermia, that is temperature regulation and monitoring. Why this topic is important? Because general anesthetic decreases threshold for vasoconstriction and shivering by 2 to 3 degrees centigrade. Anesthesia induced impairment of thermoregulatory control combined with cool temperature of the operation theatre makes patient more hypothermic. The mammals are homeothermic. They require nearly constant internal body temperature. When internal temperature deviates significantly from normal, metabolic functions usually deteriorate and death may result. Normal internal core temperature is around 37 degrees centigrade in humans. Now we will see about the normal thermoregulation. Thermoregulation is based on multiple factors. The signals from nearly every type of tissue comes to the hypothalamus. Process of thermoregulatory information occurs in 3 phases. Number 1 is afferent thermal sensing, second is central regulation, third is efferent responses. Now we will see about afferent input. The information on temperature is obtained from thermally sensitive cells throughout the body. The cold sensitive cells are anatomically and physiologically distinct from that warmth. The warm receptors increases their firing rates when temperature increases. The cold receptors do so when temperature decreases. The cold signals travel through A delta nerve fibers and warm information is received by unmyelinated C fibers. The C fibers also detect and convey pain sensation, which is why when there is intense heat cannot be distinguished from sharp pain. Most of the ascending thermal information travels via spinothalamic tract in anterior spinal cord to the hypothalamus. Now we will see about the central control. The temperature is regulated by central structure, that is hypothalamus. The efferent responses. The body responds to thermal stimuli via effector mechanism. These mechanisms are: number 1, increase in metabolic heat production or environmental heat loss or heat loss to the environment. Then we will see about the thermoregulation during general anesthesia. The response threshold, propofol, dexmedetomidine, alphantanil, all produces slight linear increase in sweating threshold with marked and linear decrease in vasoconstriction and shivering threshold. Isoflurane and desflurane also slightly increases sweating threshold. Volatile anesthetic agents inhibit vasoconstriction and shivering less than that of propofol. Responses in infants and elderly. The thermoregulatory vasoconstriction is comparably impaired in infants, children and adults when isoflurane is given or halothane is given. Then we will see development of hypothermia during general anesthesia. Inadvertent hypothermia is far and most common in perioperative period. Hypothermia results from combination of anesthetic induced thermoregulation and exposure to cold operating environment. Now first is heat transfer. Heat can be transferred from patient to the environment. In how many ways? It is transmitted in 4 ways. Number one, radiation. Second is conduction. Third is convection. And fourth is evaporation. Among these mechanisms, radiation and convection contribute most of the perioperative loss. Conductive heat loss is proportional to the temperature difference between two adjacent surfaces and strength of the thermal insulation separating them. Another is sweating increases cutaneous evaporative losses but is rarely during the anesthesia. In absence of sweating, evaporative loss from the skin surface is limited to less than 10% of the metabolic heat production in the adult. Now we will see the pattern of intraoperative hypothermia. Hypothermia during general anesthesia develops with a characteristic pattern. There is initial rapid decrease in core temperature. Then it is followed by slow and then linear reduction in core temperature. Finally, core temperature stabilizes and subsequently remains virtually unchanged. The volatile anesthetic agents cause vasodilatation via direct peripheral action. The anesthetic induced vasodilatation increases cutaneous heat loss, but it is only slightly. The anesthetic reduces metabolic rate. How much? It is about 20 to 30% reduction in the metabolic rate. Thus, the combination of increase in heat loss and reduction in heat production can explain reduction in temperature by 0.5 to 1.5 degrees centigrade. Therefore, there is a decrease in core temperature, and this is generally observed during the first hour of the anesthesia. After initial redistribution hypothermia, core temperature usually decreases in slow and linear fashion and for 2 to 4 hours. This reduction results simply from heat loss exceeding metabolic heat production, and the rate at which core temperature decreases depends on differences and size of the patient. After 3 to 4 hours of anesthesia, core temperature usually reaches a plateau and remains virtually constant for the duration of surgery. The core temperature plateau may simply represents a thermal steady state, that is, heat production is equal to heat loss. Then we will see about neuraxial anesthesia. Neuraxial anesthesia and thermoregulation, heat balance and shivering. Autonomic thermoregulation is impaired during regional anesthesia. Intraoperative core hypothermia may occur. Thermoregulation. Epidural anesthesia and spinal anesthesia decreases the thresholds triggering vasoconstriction and shivering. There are two thresholds, trigger for vasoconstriction and trigger for shivering. Both are decreased during epidural and spinal anesthesia. The vasoconstriction and shivering thresholds are commonly decreased during regional anesthesia. Regional anesthesia blocks the thermal input from block regions, which in typical case is a primary cold information. Because neuraxial anesthesia prevents vasoconstriction and shivering in block regions, it is not surprising that epidural anesthesia decreases maximum intensity of shivering. Neuraxial anesthesia is frequently supplemented with sedation and analgesic medication that again impair the thermoregulatory control. Now we will see about heat balance. Hypothermia is common during regional anesthesia and may nearly severe during general anesthesia. Core temperature typically decreases by 0.5 to 1 degree centigrade shortly after induction of anesthesia. Vasodilatation induced by the regional anesthesia only slightly increases cutaneous heat loss. But again, metabolic heat production remains constant or increases because of shivering and thermogenesis. Now we will see about something about shivering. What is shivering? Shivering, like tremor, always preceded by core hypothermia and vasoconstriction. The electromyographic analysis indicates that the tremors has 4 to 8 cycles per minute and there is waxing and waning pattern that is characterized by the shivering. The risk of shivering during neuraxial anesthesia is markedly diminished by maintaining strict normothermia. Shivering during anesthesia can sometimes be treated by warming the skin. And we can give the drugs also. The drugs are meperidine in the dose of 25 mg IV, or it can be given epidurally. Clonidine 75 microgram IV. Dexmedetomidine can also be given, and magnesium sulfate in the dose of 30 mg per kg IV can be given. Now we will see about the benefits or consequences of the mild intraoperative hypothermia. First, we will see the benefits of mild hypothermia. The substantial protection against, what is the benefit? There is protection against the cerebral ischemia and hypoxia, which is a benefit of hypothermia. The production was usually thought to result of approximate 8% degree centigrade linear reduction in tissue metabolic rate. The therapeutic hypothermia has twice been shown to improve outcome after the out of hospital cardiac arrest. The potential protection afforded by mild hypothermia is increasingly used during neurosurgery also. Hypothermia for brain trauma was initially claimed to be therapeutically based on the post beneficial in the patients of brain trauma. Also, mild hypothermia improves outcome after the stroke. Hypothermic protection against ischemia may extend to the other organs also. Hypothermia markedly reduced infarct size in acute myocardial infarction. Now we will see about the complications of mild hypothermia. Now, first and foremost complication is about coagulation. Coagulation is impaired by mild hypothermia. Why this occurs? Because of cold induced defect in platelet function. There is also increase in blood loss due to hypothermia in hip arthroplasty. There are increase in allogenic transfusion requirements. There are chances of wound infection. Why there is wound infection? It is triggered by thermoregulatory vasoconstriction, which in turn decreases the oxygen delivery to the wounds, and there are chances of wound infection. Then post-anesthetic shivering. The incidence of post-anesthetic shivering is reportedly about 40%. It is potentially serious complication. Why? Because it increases oxygen consumption roughly 100% in proportion to the intraoperative heat loss. Myocardial ischemia can occur because of the shivering. There is increase in intraocular and intracranial pressure. Again, shivering can aggravate wound pain. How? By stretching the incision. The post-anesthetic shivering can be treated by number 1, skin surface warming, because the regulatory system tolerate more core hypothermia when cutaneous warm input is augmented. The pre-anesthetic shivering can be treated with all the various type of drugs. Number 1, clonidine, dose 75 microgram IV. Then tramadol, dexmedetomidine and magnesium sulfate. Now we will see prevention of perioperative hypothermia. Number 1, airway heating and humidification. The simple thermodynamics calculation indicates that less than 10% of metabolic heat production is lost via respiratory tract. Therefore, airway heating and humidification decreases chances of hypothermia. Second, IV fluids. Whenever 1 unit of refrigerated blood or 1 liter of crystalloid solution is administered at the room temperature, each decreases mean body core temperature approximately 0.25 degrees centigrade. The fluid warmers minimizes these losses, and it can be used when we use large amount of intravenous fluids and blood. Third is cutaneous warming. Increasing room temperature is one of the way to minimize the heat loss, but room temperature exceeding 23 degrees centigrade is required to maintain normothermia. The easiest method to decrease cutaneous heat loss is to apply insulation of the skin surface. Insulation is available in the most of the operating rooms. It includes cotton blankets, surgical drapes, plastic sheets. Single layer of each reduces heat loss up to 30%. Then we will see the severe intraoperative hypothermia and deliberate severe intraoperative hypothermia. Organ function. Hypothermia, that is deliberate, decreases the whole body metabolic rate, and it decreases metabolic rate up to 8% per degree centigrade decrease in temperature, approximately one half of the normal rate at 28 degrees centigrade. Then whole body oxygen demand also diminishes or decreases. Oxygen consumption also decreases in the tissue that have higher than normal metabolic rates, such as brain especially reduces. Brain oxygenation is improved thus by hypothermia. Cerebral blood flow also decreases. Cerebral function is well maintained until the body temperature reaches to 33 degrees centigrade. Hypothermia also decreases blood flow to the kidneys. And acid base changes. The pH of neutral water increases by 0.017 unit for each 1 degree reduction in the temperature. Temperature monitoring. How we monitor the temperature? Core temperature measurement can be done by tympanic membrane measured with the thermocouple, pulmonary artery, distal part of the esophagus and nasopharynx. Both core temperature and skin surface temperature are measurements are required to determine the thermoregulatory effects of all anesthetic agents. We monitor temperature monitoring is done by the thermometers. There are mercury in glass thermometer. They are slow and cumbersome, and other is electronic system. The electronic thermometers are accurate and routinely used. What are the temperature monitoring sites? These sites are: number 1, pulmonary artery; second is distal part of esophagus; third is tympanic membrane; fourth is nasopharynx. These are the sites. Now we will see temperature monitoring and thermal management guidelines. The core temperature should be measured in the most of the patients giving general anesthesia for longer than 30 minutes. Second, temperature should also be measured during regional anesthesia when changes in body temperatures are intended, anticipated, or suspected. Third, unless hypothermia is specially indicated for protection against ischemia, efforts should be made to maintain intraoperative core temperature higher than the 36 degrees centigrade. In summary, body temperature is normally controlled by negative feedback mechanism in the hypothalamus that integrates thermal information from most of the tissues. Second, approximately 80% of the thermal input is derived from core temperature, which can be measured with distal esophageal, nasopharyngeal, tympanic membrane by use of thermometers. The hypothalamus coordinate increase in heat production by non-shivering thermogenesis and shivering, increases in the environmental heat loss by sweating, and decreases heat loss by vasoconstriction. The thermal steady state requires that heat loss to the environment, it should be equal to the metabolic heat production. Hypothermia occurs when heat loss exceeds the production. The mild core hypothermia is common during surgery and anesthesia. This results initially from the redistribution of body heat from core to peripheral tissues, then subsequent from heat loss exceeding to the metabolic heat production. The clinical doses of general anesthetics decreases the threshold response to the hypothermia from approximately 37 degrees centigrade to 33 to 35 degrees centigrade. Mild intraoperative hypothermia provides significant protection against tissue ischemia, hypoxia. The metabolic heat is lost via respiratory tract. Even active airway heating and humidification are of benefit. Administration of sufficient volumes of cold intravenous IV fluids can also produce substantial hypothermia. Fluids therefore should be warm in patients requiring intravenous administration, then several liters per hour. The fluid warming should always be secondary to active cutaneous warming. The forced air offers best combination of efficacy and safety. Regional anesthesia produces both peripheral and central inhibition of thermoregulatory control. Peripheral inhibition results when local anesthetic block nerve that are required for thermoregulatory defenses. Then hypothermia during neuraxial anesthesia results initially from core to peripheral redistribution of body heat. Then when heat loss exceeds the heat production. Hypothermia during major conduction anesthesia may be as severe as during general anesthesia. Next, increased core temperature can result from augmented thermogenesis. That means malignant hyperthermia. The reasonable strategy for detecting and preventing thermal disturbances is to monitor core temperature in the patients in whom general anesthesia will last longer than 30 minutes. Thank you.